Welcome back to Breathing for Better Sleep with Dr. Fred Eck, the podcast that explores natural root cause solutions for sleep apnea, snoring, and childhood sleep challenges without CPAP or surgery. In today's episode, we're talking about the mask, the machine, the moment so many patients give up, not because they're lazy or not compliant, but because the model failed them. If you ever felt frustrated, defeated, or even hopeless with CPAP, you're not alone. Dr. Eck is here to unpack why so many people hit a wall and what's possible beyond it. How are you, Dr. Eck?
I'm doing great. How are you?
Good, thank you. So many questions about CPAP today. I know it's the go-to solution for sleep challenges or sleep disorders, but we want to tell our audience what they can do beyond this, because I know it doesn't work for a lot of people. So you've worked with thousands of patients with sleep apnea. How many of them started with CPAP and just couldn't make it work?
I'd say probably about half of our consults that we see have tried and failed, or it just doesn't fit into their lifestyle. If they travel a lot or in RV campers, whatever, it just doesn't work for them. So I would say it's probably about half of our patients. And a lot of them, they're wearing this CPAP and they think it's working, but then they find out it's not. And so, they're looking for alternatives. The CPAP we'll talk a little bit later on about it, how the CPAP is a standard of care and why it is and why it should not be. We recently had a patient who was in for a follow-up that we treated, finished his case like a year ago. He was in for a follow-up. And he's a perfect example because he was told that his CPAP was working according to the chip in his CPAP, which they use for monitoring, but they're not accurate like a sleep test is. But he was told it was working, but in his mind, it wasn't working because his chief concern was his wife would not sleep in the same room because of the snoring. So the whole reason he's doing this is because of the snoring. Well, the machine makes so much noise that the wife still won't sleep in the room. So it hasn't even solved his chief concern, right? The other problem we'll talk about a little bit later on is that sleep is a progressive disorder. We talked about this a little bit before. If you don't fix the problem, the sleep is going to progress. If I redo your sleep test in 12 months, it's worse. Another 12 months, it's worse. A CPAP does not stop that progression. So, for instance, in his case, his initial sleep test in 2021 showed an AHI of 17, which means he stopped breathing 17 times an hour, right? When I saw him in mid-2024, we updated his sleep test, both one night without it and one night with it, so we could see how well it was working. And the progressive nature of sleep is his AHI, or number of times that he stopped breathing per hour, went from 17 to 27. Now, his test that we did with his CPAP, he still had an AHI of 18. So it was not working. So the one thing I warn all patients about is if you're wearing a CPAP, make sure you get a sleep test with it in place. Do not rely on those chips on the computers. Without the updated sleep test, he would have known it wasn't working. So thankfully, he was out looking for a solution for his snoring.
Should a patient using a CPAP get a sleep test every couple of months, let's say, or initial test and then see if it's working for the person past a determined amount of time of using the CPAP?
Yeah, so whether they're doing a CPAP, an Inspire surgery, an oral appliance, whatever option that they choose, they should get what we call an efficacy study, which means usually somewhere between 30 days and 90 days. Okay, we get an updated sleep test. If we're doing epigenetics or things that take longer, it could be a longer time period, but at some point you want a sleep test with your device in place to confirm it's actually working. And then every few years, what I normally recommend most patients is about every 3 years, you update your test to make sure you're still getting efficacy of your treatment.
Yeah, I can imagine that so many people just get prescribed a CPAP and then they just use it for however amount of time and then they just think that because it was prescribed is going to work, but they never question. Well, I know that happened with my dad. Like, he got prescribed a CPAP and he was just using it forever. I don't know if he got a test for it later on to see if it was working or how much he was improving. So that's a good thing
Well,
too.
it's kind of a failure in the system because if you get prescribed an oral appliance or myofunctional therapy or an Inspire sleep implant, the doctor is always requesting that efficacy study to see how well it's working. But for some reason, when they prescribe a CPAP, they don't ever request that. And the mindset is because it is the quote unquote standard of care, this is as good as it gets. So if it's not working, well, that's as good as it gets. And we're going to talk about that today and a lot in the next coming up episodes that's not adequate. It's not sufficient. And there are better solutions for those people.
When someone walks into your office after failing CPAP, what's their emotional state? Are they angry, ashamed, defeated? What happens then?
You're talking about for people who have tried a CPAP?
Yes, people that have tried a CPAP, but they feel like they're not sleeping any better and they come and see you. How do they feel?
It's mostly frustration because they've done what the doctor said, even though they didn't want to wear the mask. They've tried, they've gone through multiple masks, and rather than tell them, hey, there's alternatives, they're told to try another mask, try harder. And these people will try 6 or 8 masks. Well, it's not that they're not doing what they can. It's just not working for them. So they get frustrated. And you can't blame them.
Have you ever treated a patient whose CPAP experience was so negative it actually made them fear getting help at all?
It happens all the time because they go through the scenario I just mentioned, and again and again and again, they're trying a nasal mask, they're trying a full mask, they're trying a different hose, they're trying it with humidity, they're trying all the different stuff they can, and nothing is working, and so they get frustrated and fearful because they don't believe there's a solution, because they figured if there was a solution, somebody would have talked to them about it, right? Rather than trying to give them 8 different masks. And so they believe the only solution outside the mask is surgeries. Right? And so they don't want to do surgeries. They're afraid of those. And the mask isn't working. So yeah, they just get frustrated and quit.
And why is CPAP considered the gold standard? And why does that model fail for so many people?
We're going to have in the next few episodes a lot of conversation about why the CPAPs and when they don't work and how we can kind of somewhat predict it. But to answer the question as to why it's a standard of care, there is no good reason. It's 1980s, 1990s, and their sleep is so progressive, and there's so many better options today that are as effective or more effective for many, many patients. So it should not just be the go-to standard of care. There are doctors right now researching the long-term effects of these, and we'll get into those long-term effects. But most doctors are just not keeping up with the most recent research showing the downside to the CPAPs, right? And last but not least, one of the big reasons why CPAP is the standard of care is because it's insurance driven. So insurance companies are very, very slow to change, right? And so they have not caught up to the times. Sleep is a very rapidly progressing field. And unfortunately, insurance companies are stuck in the 80s. So they pretty much approve the things that they were approving in the 80s and 90s. And so that's what the doctors chase. In our office, if you want what the insurance covers, that's fine. If you want something that's better than that, where you got partial coverage, then you can look at the alternatives. But it's driven a lot by insurance.
And is it also because sleep treatments that are not CPAP are costly? Like, why are they not insurance?
It's not as expensive as many of the things that these patients deal with in their medical history. All the problems that are being created by the sleep apnea can be very expensive to deal with. It's just that if you're going outside of the CPAP, there are out-of-pocket costs. You might get half covered instead of 80 or 90 or 100%. Now, with that said, a lot of people don't look at the long-term cost. So CPAP day one is the cheapest option to go with, right? But there's a lot of maintenance to a CPAP. Cleaning solutions, changing out the hoses and the mask and all the cleaning solutions. I mean, the average person spends like $700 a year. So once you have a CPAP for 5 years or 10 years, it's no longer the cheapest alternative, right? And the other important part of that, thinking about the cleaning side of it, I always tell patients when they decide they want to do a CPAP, I ask them a question. Do you floss your teeth every day? Do you take the time to floss your teeth every day? The reason why this is important is because what percentage of the population actually does that? 5, 10%, right? Well, if you won't spend that much time taking care of your teeth, are you going to take the proper amount of time to take care of a CPAP? Because a dirty CPAP we know is really bad for you and your lungs. And if you won't take that time to clean it properly every single day, it can be bad for you. In fact, there's a lot of data out there right now, and doctors are researching the long-term effects of these CPAPs. And one of the things that they've concluded recently is in the last 50 years that we've been prescribing CPAPs, it's done nothing to reduce the overall risk of heart attacks. And we'll talk in a future episode about why that is. But if you want to talk about effectiveness, let's use the concept of what's called mean disease alleviation, MDA. What that means is how effective is something, right? And most doctors are not aware of these studies and the effectiveness, the true effectiveness of things, okay? Most doctors think a CPAP is the most effective, but the best study ever done that I've ever been able to find shows an effectiveness of 55%. Now, when you look at effectiveness, you got to take into compliance. Are they wearing it the amount of time and all this other stuff? Okay. Old school dental appliances like we used to make, and or even up into the early 2000s to 2010 or so, those had about a 45% success rate. But what was the CPAP success rate in the same studies? 55%. So it's not much higher. If we look at our precision appliances and epigenetics and myofunctional combinations that we can do today, we can get success rates in the 85% area. I can't get that with a CPAP. In fact, the studies show 55%, but I believe the true success rate of CPAP, if you look into everything, is really only about 30%. Because if you wear a CPAP for 4 hours, that's all that was required in the study to show compliance, right? Because that's what insurance companies require. But we know for health reasons, you have to wear a CPAP 6 or 7 hours, right? So if you stop breathing 40 times an hour, right, as your baseline number, you wear a CPAP for 4 hours and it takes it down to 2 times. Okay, for those 4 hours, you're great. But for the next 3 hours after you take it off, go back to sleep for the rest of the night, and now you're sleeping 30% of the night or 40% of the night, at least, okay, another 3 hours, with your AHI back up to 40, how well is it working for you if it's sitting next to your bed? You know how many people pass away from heart attacks that have a CPAP machine sitting right next to them? That's not very successful.
Do you think that a lot of people, well, apart from everything that you've mentioned, do you think that they choose a CPAP because it's easier to comply to a CPAP? Like, I know it's uncomfortable, but when you mention the combination of epigenetics and myofunctional therapy, and it seems like they have to do a little bit more work, and people have a hard time committing to having to do some work. But I feel that doing the work and what's necessary for your health is really the only way of getting to the root cause of a problem. What do you think?
I don't think that's, for the most part, that's not why most people choose a CPAP. We're going to get into the next couple episodes where we're going to be talking about the different treatment options, all of them. When we see patients for consults, there's 12 or 14 different options that every patient has. There's always more than one that will work for them. And we're going to get into the future episodes about each of these and the time it takes and all of that stuff. But a CPAP is not easy. The average person cannot comply with it, cannot adapt to it. And the time it takes, as I just mentioned earlier, the cleaning and everything else. There's a lot of people who don't want to wear it and can't wear it. So when most people choose a CPAP, it's for one reason and one reason only, typically. It's the cheapest upfront way to treat. That is the number one by far reason why anybody chooses a CPAP.
What do you think it would take for other option treatments to be part of the healthcare?
I don't know, honestly. I don't think in my career it's ever going to happen. I mean, it hasn't happened in the last 40 years. Okay. We cannot get insurance companies off what they started treating back at the beginning, which is CPAPs and some very basic appliance options and a couple of the basic surgeries. Okay. I don't think that's going to change in my career. Insurance companies are not interested in prevention or doing what's right for the patient. They're out there to make money. Every town in this country that has a big building in it, the biggest one's usually owned by an insurance company, right? In downtown. That's just the way it is. They're not here for us. I can give you a personal example that just happened to me. I had a colonoscopy last month, and I'm 54 years old. So I've been told by my doctor since I'm 50, I need to have one because that's the standard of care, right? So I finally get one, and the insurance company doesn't cover it because it's preventative. And I don't have an active problem. They don't care about preventing stuff. And unless you care about that, they're never going to get on board with fixing sleep properly. That's why we have such a problem with kids. Insurance companies just don't do anything to help with kids with airway, and it's disgusting.
Yeah, absolutely. How could we be as a population if we were able to prevent better, or if the system supported prevention rather than just fixing? And so going back to the CPAP, you've talked about using CPAP as a short-term tool. Do you ever prescribe a CPAP, or is not part of your practice?
We do prescribe CPAPs. We do tell patients to use CPAPs in certain instances. Pretty much it's based on their medical history and how much the oxygen desaturations or how much time they're spending with their oxygen under 90%, because that's the one thing a CPAP does quickly is reverse that. But it quickly makes your deep sleep worse as well. So depending on the patient and what we're trying to accomplish, I see patients with severe sleep apnea who don't spend more than 1 minute with their oxygen below 90%. Okay? And I see people with mild sleep apnea. That just had that last week. Mild sleep apnea, AHI of 6.7, spent 2 hours of the night with oxygen under 90%. So it just goes back to that AHI number is not what we treat to. It's one number on a sleep test, and it's the least important number on a sleep test with zero science behind it. So we look at the entire person, symptoms, and that. But the other thing you got to look at, so when we prescribe it, we're normally telling the patient it's a short-term solution. We're normally doing it in combination therapy with something else, and utilizing it in the short term until we can get some of the longer-term results. Because CPAP, what we're trying to do is cure, right? We're trying to fix the problem, not manage or mask the problem. Because if you cure it, you can stop the progression. If you don't, and you just manage it, which is all a CPAP mask does, then the sleep problem progresses. That's why every few years, you got to turn the pressure on a machine up for it to keep working, because the process is progressing. And once that pressure gets above an 8 or a 9, we're now understanding the health consequences from that. So oftentimes we'll have people with a CPAP and they're happy with their CPAP. They feel good. Everything else is good. But now they're learning that if their pressure is above a 10, up at 12 and 14 and 15, that they actually increase their chance of a heart attack, not decrease their chance. So some patients are coming in trying to find solutions, things that they can add to their CPAP, just so they can wear their CPAP but get their pressure down between 4 and 7.
And Dr. Eck, no matter how advanced the sleep disorder is, can it be cured? Or is there a point where it's so advanced that you can't cure it anymore?
It is easier the earlier you catch it, of course. It is more costly and time consuming the later that you catch it. But no, we take severe sleep apnea patients and cure them all the time. We take people with central apneas, which I want to guess how many people in medicine understand that you can fix central apneas without a BiPAP machine? Not many. We take people with 60, 70, 80, 90 centrals down to 5 or less on a routine basis without a mask.
Can you just clarify what central sleep apnea is versus severe sleep apnea?
So central apnea there's two types of apnea. One is obstructive apnea, which is related to the anatomy and restrictions in your airway. Okay? There's a restriction somewhere. That's what causes the snoring. That's what causes us to stop breathing. There's essentially, you've heard me use the kink in the hose analogy, right? There's a kink in the hose somewhere. Okay? Then what happens is our oxygen goes down because we stop breathing. And if you're in the hospital on a monitor, your oxygen should be 98, 99, 100%, right? If it drops by 4% or more, then a nurse walks into the room to see what's going on. If your oxygen gets down to 90% or below, that's actually considered a medical emergency, and an emergency team comes into the room. The reason for that is because we know oxygen at 90% and below is causing organ and tissue damage. It's that organ and tissue damage that results in the second type of apnea called a central apnea. It's called a central apnea because it's related to your central nervous system, your brain. Your brain no longer responds properly to the stimulus to breathe. So there's two different types of apneas. And so typically if you improve the obstructive apneas, then you will ultimately improve oxygenation and the central apnea start to get better. But with epigenetic treatments, that we're learning that is helping tremendously with central apneas.
And this only happens when you sleep, Dr. Eck? And why does it only happen when you sleep, if so?
When you're awake, when you're sitting up, you can control your breathing. You're not gonna stop breathing when you're sitting up and awake. It's when you lay down and you fall asleep that you don't have any control over keeping your breathing going. And that's why you have these obstructive events, because you're getting a collapse in the airway somewhere. You're getting something in the way. And that's what's causing the problem. And these tissues and everything get more relaxed, get more in the way, or tongue falls back into the back of the throat. All of these things happen when you sleep.
But if you do have sleep apnea and there's obstruction at night, you're probably not breathing properly during the day either, no? Or there might be some obstruction also during the day. It won't stop you from breathing, but maybe the quality of your breath isn't as deep as it should be.
Oh, yes, for sure. So it won't stop you from breathing simply during the day, but it will definitely alter how you breathe. So there are people, I was just talking to a guy the other day. He wears nasal strips 24/7. He wears nasal strips in the middle of the day in order to breathe. So, and if you're breathing through your mouth, remember that's abnormal. We're supposed to breathe through our nose, not through our mouth. So if we can't breathe through our nose, even when we're awake, okay, and we're mouth breathing, that's abnormal, which creates its own problems, especially the growth patterns in kids. Mouth breathing in kids is really, really bad.
I've been focusing a lot on noticing how I'm breathing and how my mouth is positioned when I'm awake, just to understand if there's something there. And I notice sometimes like my bite is off. Are your teeth supposed to be a little separate from each other, even if your lips are against each other? You mentioned that your tongue should be in the back of your palate, but are your teeth supposed to be together, or can they be a little separate?
So typically if you're awake and you're sitting up, then your tongue should rest up against your palate, up towards the front, behind not touching the front teeth, but behind them. And then it should curl up and rest against the palate. And then the lips should be closed and sealed. And the teeth for most people are a little bit apart during the day. You can clench, you can grind, okay? and your teeth obviously come together thousands of times a day, every time you chew food, swallow, etc. It's not that they stay apart the whole time, but just in resting, your teeth, for most people, do not come together.
Okay, and that's a good positioning for
Yes.
for people. Okay, awesome. So if CPAP isn't working, what other treatments are out there, and how do they actually fix the root cause? You've mentioned myofunctional therapy. What else can people be aware of that they probably don't know?
Lots of options, and when we get into these next two episodes, we're going to spend a lot of time on each one, so everybody can understand them. But there are so many different options, and it all is dependent upon the root cause. So if somebody wants to actually treat their airway in the most predictable manner, then your first step is to see a dentist or an ENT that is focused on airway treatment, and get an evaluation and find out where the obstructions in the airway are. That is the only way we know which options are best for you. And a lot of times it's a combination of options. You can expand the palate and make more room for the tongue. By expanding the palate, you actually also widen your nasal airway without surgery. Okay. There are oral appliances designed just to move your jaw a little bit forward so your tongue can get out of the way. There are laser therapies that are designed to shrink the tissues of the soft palate, the tonsils, the uvula, etc., base of the tongue, in order to create a better opening. There's radio frequency machines that a lot of ear, nose, and throat doctors will use to help, in a very simple way, shrink the size of the tissues in the nose, the concha, etc., in a much less traumatic way than the old school type of surgeries. Myofunctional therapy, as we talked about, that's learning breathing exercises and breaking the habit of mouth breathing. There's lots of research in the last several years that show if you combine, and that's how we take a severe patient, by the way, to normal, is combination therapy. It's not one magic pill. Okay. So you do therapy and you add something else to it, like myofunctional therapy. And myofunctional therapy by itself can reduce the incidence of apnea events by 50-60% in some patients. And that's the primary way that we treat children, by the way, is myofunctional therapy. That's the number one most important thing for children as far as their treatment plans are concerned. And there's surgical options, there's dental options, there's even certain supplements that are good for sleep patients, things like vitamin D and collagen. And when we talk about all these different treatment options in these future episodes, we're going to go through each one. And one of those areas is actually nutrition as well.
Dr. Eck, and are you able to channel people in your practice to the best option for them? Like, do you use all these treatments? The combination of them?
Yeah. So, I mean, we do a lot of different options in our office, and we work closely with ENTs and surgeons and myofunctional therapists, craniosacral therapists, and a lot of these people. And as I mentioned before, the more severe you are, the more likely you are to need more than one of these modalities to get back to normal. And so we have a whole group of doctors that we work with, so that if it's something that we don't do, but you're going to benefit from it, we'll make sure you get, to that doctor and that treatment.
Okay, awesome. So when anyone comes into your office, they can trust that they'll be channeled to the best solution for them.
That's our ultimate goal. We want to make sure they get fixed, and them getting fixed is not always what we do. Them getting fixed can involve other things, and if those other things are better for them, then we send them to the right place. At the end of the day, I want to see an efficacy study, whether we treat them or somebody else treats them. I want to see an efficacy study that's going to show they're being treated well. And if I know that somebody else has an option that's better for this person, then, I want to make sure they get there.
Fantastic, Dr. Eck. And what would the patient experience look like if airway-first sleep care was the starting point and not the backup plan?
Let me start by defining airway first. So This means that we evaluate, as I mentioned earlier, through an ENT, through a dentist, through 3D imaging. We evaluate what is causing the restrictions in the airway and where in the airway are those restrictions. This again is how we determine root cause of the airway problems. If we did that, it would be a much better experience and prevent a lot of issues that cause frustration with the airway patients today. Airway first means correct the airway obstructions. Don't mask the problem by just throwing a mask on it. And it doesn't fix most patients. And does it mean it never needs to be done? No. Does it mean it needs to be done sometimes in combination with other things? Yes. But this whole model we have now of diagnose sleep apnea and throw a mask on them, it's got to change. As I mentioned earlier, we mentioned in medicine, we can be treating a problem or we can be managing a problem, right? So if you have cancer and you say, all I want to do is manage pain and not treat the cancer, that's managing the problem, right? And managing the symptoms. That's not curing anything. But if you say, hey, I'll do surgery or I'll do radiation, whatever it is, I want to treat the problem, which means cure the problem, right? So there's a difference between treat, cure, okay, and management, treat symptoms. All a CPAP does is treat symptoms. Doesn't cure or treat anything. It addresses symptoms, and that's it. So I would encourage people to try to treat the problem, because otherwise it's going to continue to progress. And the longer it progresses, the harder and the more expensive it is to treat.
Yeah, and the more effects it has on other systems of the body, right? So just to clarify, let's say CPAP, it's like if you have a fever, you take Tylenol to kind of stop the fever. But then the fever is not the problem. The fever is just a symptom. But once you get the fever down, then you need to treat the root cause that could be, per se, a stomach infection. So you have to treat the infection. So CPAP could work to help with a symptom for a little bit, but with that, you have to be doing other things that are actually helping you better the root cause.
Helping you fix the problem, yeah.
Fix the problem.
Cure the problem, yeah. So they're great to be used temporarily for symptoms, but they're just they're not good for long term for most people.
Okay. And sleep disorder is always an airway problem?
Sleep disorder, and keep in mind, we're talking about sleep apnea and snoring and all this a lot, but sleep apnea is one sleep disorder. There's like over 60 sleep disorders, right? And not all sleep disorders are caused by airway restrictions. There are some things like certain insomnia cases. So insomnia, by the way, is I would say in the order of what's the word? Not importance, the order of most common. Okay. Sleep apnea is probably the second most common sleep disorder we have. The number one most common sleep disorder we have is actually upper airway resistance syndrome. And insomnia, I think, falls third, right? But what is the most common cause of insomnia? Sleep apnea. You fix the sleep apnea, correct the sleep cycles, and the insomnia goes away. But there are insomnia patients that have a neurologic or a psychological component to them, and they're not related to restrictions in the airway. So there can be other causes of sleep problems, and there can be some simple things like acid reflux, epilepsy. There's lots of different things that can contribute to a sleep disorder. And a lot of the sleep disorders can contribute to those things as well. That's why you have to get to root cause. You got to figure out what's more likely to be causing the problem and treat that.
Yeah, I guess it can become a vicious cycle, right? In sleep apnea, causing insomnia, and then insomnia feeding into the loop of like the sleep disorder.
Yes, it definitely could become a whole wheel.
So we're approaching the end of our episode, Dr. Eck, but I want to ask you one last question. What do you want patients to know when they're on night 3 staring at the ceiling with a mask they hate?
Oh, they're just starting? Well, I would say just understand that you have hope, you have options, and if you let us figure out what the root cause is, we can find a cure for you.
This is so important for everyone listening. I know that a lot of people struggle with sleep disorders, with sleep apnea. I know the population is increasing who have these sleep problems, and there is hope for you. So thank you, Dr. Eck, for sharing all this information with us today. And we're looking forward to the next episodes when we can go deeper into what options people have.
Thanks for having me. I'll see you soon.
That is it for this episode of Breathing for Better Sleep. If you've tried the gold standard and it didn't work for you, you're not the failure, the system is. And there are real solutions that not only involve a lifetime behind a mask. Subscribe to watch future episodes and visit sleeptreatmentdirect.com to learn more about working with Dr. Eck. And if this episode hit home, share it with someone else who's struggling. You might change their life.